of tumor microenvironment. So the challenge, as I said before, is to be able to detect IDO or TDO. And I think we talked about it very briefly earlier, that if you have a increased IDO or TDO, the end result is the same, that you have increased regulatory T cells. So if you have difficulty with actually enriching for IDO or TDO, you can actually just look at regulatory T cells and identify patients who would benefit from this. So I think a dual IDO TDO inhibitor would actually help potentially have cover both pathway upregulation, and also it might be easier for a biomarker strategy. Like, you know, if you're looking at regulatory T cells and you have a drug that actually blocks both IDO and TDO, might actually offer a better enrichment of patients who could respond for such a strategy.
Okay. Do you think the efficacy would be better?
Yeah, I would think so. It would probably cover more patients, and it would avoid any adaptive resistance that might emerge from an IDO inhibitor. If you treat with an IDO inhibitor, there could be a TDO upregulation. You know, I think it might be better, but again, at the same time, you also have to keep in mind there might be some increased toxicities as well.
That was my next question. What makes you say that? What would you be concerned with?
I suspect, I think, you know, we might see like more toxicities because there might be different immune tolerance microenvironments in the lung or other places where there might be increased, the more TDO or IDO related immune suppression. But
so more IDO related immune suppression.
Right.
So which of IDO or TDO, if either, has the stronger scientific rationale in your mind?
Yeah, it's hard to compare it that way, but I think both of them are different. Like, you know, the end result is the same: increased regulatory T cells in the tumor. However, I think you know, both of them do the same thing. However, they work in a different way. But if you have an inhibitor for IDO and TDO, the end result is there's going to be less Tregs in the tumor microenvironment.
Okay. So, if I ask you, what clinical value does the TDO2 inhibitor component of a dual IDO TDO inhibitor add?
So I think clearly you know, there's potentially decreased primary resistance to PD-1 inhibitor, and also potentially could be used in the second line setting after immune checkpoint inhibitor, where, you know, there could be some acquired resistance to the PD-1 inhibitors. So I think you know, it could be used in both settings, and of course, you know, we need to generate the clinical data.
Are there any additional tumor types which you would anticipate a dual inhibitor of IDO TDO would make it more viable?
I can't think of anything at this point, but I think a combination with a checkpoint would be a good strategy. I think those are approved for various tumor types now.
Okay. And what would you want to see? What level of efficacy or duration of response or progression-free survival would you want to see in order to use an IDO TDO dual inhibitor in your patients?
Well, it depends on the tumor type and the indication. So you have to look at the current standard, and you know, it has to be obviously better than the current standard.